So the MANIFEST study, I think, is an important study that's ongoing. That is a phase 2 trial evaluating a novel pan-BET inhibitor called CPI-0610. This is an oral drug that's taken 2 weeks on, 1 week off in a 3-week cycle, and evaluated the drug in 3 cohorts of patients. Those that had failed ruxolitinib, who were off ruxolitinib and would receive CPI as a single agent, that's cohort 1. Cohort 2 are those patients who were quote unquote failing or having a suboptimal response to ruxolitinib, who are still on ruxolitinib, would receive CPI in combination to their dose of ruxolitinib as a salvage therapy. And then cohort 3, which I'll present, which is the patients who are JAK inhibitor naive that get the combination up front of both CPI and ruxolitinib. What we've seen so far in that phase 2 study is the drug is active, whether it's monotherapy, whether it's salvage in combination with ruxolitinib, or whether it's in combination in the upfront setting. In the upfront setting in particular, what was appreciated was there appeared to be what would be considered a higher frequency of spleen volume responders, 67%, as well as symptom responders, 57%. But we also saw a reduction in bone marrow fibrosis in almost a third of the patients within 6 months of therapy. And if you look at patients who are anemic, particularly patients who have hemoglobins less than 10 and who are transfusion independent, you can see that the hemoglobin improves, the mean hemoglobin improves over time, greater than 1.5 grams per deciliter in the majority of these patients. And I've personally treated a number of these patients and seen patients with this therapy, even in the salvage setting, have responses that can be 2 to 3 years in duration of transfusion independence. So what is exciting about CPI is a very tolerable drug, some low-grade GI stuff that can be very easily managed, minimal myelosuppression in an easy-to-deliver format of 2 weeks on, 1 week off, providing additional spleen and symptom benefit, anemia benefit in a subset of patients, and even evidence of disease modification by reduction in bone marrow fibrosis in a third of patients. So this continues to look exciting. It is the data has really supported and encouraged the randomized phase 3 MANIFEST-2 study, which will enroll intermediate and high-risk MF patients with measurable spleen and symptom burden who have not received ruxolitinib or fedratinib previously, and they will get ruxolitinib plus CPI at the 125 milligram 2 week on, 1 week off schedule, with a primary endpoint of spleen volume reduction and secondary endpoints of total symptom improvement, duration of response, survival, progression-free survival. This is a registration trial. This could be paradigm shifting as it may lead to the commercial availability of an oral agent to be added to ruxolitinib to improve upon the depth of response in patients, and maybe an interesting option also for patients who have anemia, particularly at onset, in trying to reduce or alleviate the need for red blood cell transfusions and improve quality of life.